Bismillahirrahmanirrahim. So welcome all the viewers. Today we will discuss about how to master in the bad obstetrical history. Although it's a very tricky one and a difficult history, one of the most difficult of history, but let's make it easier. By the end of the video, you will be able to master in this history. So let's start. First of all, in the biodata, the important points related to the bad obstetrical history includes consanguineous marriage, maternal age, and blood group if Rh negative. So the patient can come up with either the pre-pregnancy counseling due to recurrent pregnancy loss, any history of previous intrauterine death, or any other early neonatal death, or no uh, previously no palliative. So in the or either the intrauterine death or small for gestational age in the previous or the current pregnancy. So let's begin. In the history of the presenting illness, well, there are many templates to take the bad obstetrical history. Either you start with the this current pregnancy status or with the previous bad obstetrical history. I would recommend to start with the previous obstetrical history to rule out the cause and differentials and diagnosis what has led to that bad obstetrical history in that particular pregnancy. So when talking about the obstetrical history, inquire about the pregnancy intervals. If there are any miscarriages, inquire about its type. If recurrent, APLA can be possible, which trimester miscarriage, any ENC done or not, any karyotyping done or not of that particular miscarriage. So in the OPS history, just make a table of this practical history and quickly go through all the points so that you cannot miss any of the single point related to the bad obstetrical history. Number one thing is ask about the year of child born, next place of birth, either a midwifery setup, a dye setup, any hospital, a tertiary care hospital, or any home-based setup. So then inquire about the time of delivery, trimester and month of delivery. If any problems, the first trimester problems can be related to APLA or torch infection. The second trimester can be due to cervical insufficiency. And in the mode of delivery, either SVD, spontaneous vaginal delivery, it can be either spontaneous onset of labor or induction of labor due to any particular problem. So inquire about the reason of induction of labor. Then if the cesarean section asks about either emergency versus elective cesarean section. So in the complications, inquire about the pregnancy complications. If the patient has experienced any pregnancy-induced hypertension, diabetes, any jaundice, to rule out ops cholestasis or viral hepatitis or any torch infection. In the intrapartum, inquire about the any presence of meconium if the patient knew that, any aberrant lighter, both polyhydramnios and oligohydramnios, any history of placental abruption, and history of obstructed labor. So in the postpartum history, inquire about any ICU admission, any prolonged hospital stay, any history of anti-D admission or not. Then ask about the gender and the weight of the baby, whether it was IOGR or any low birth weight. If any anomaly is present and if the patient has seen her baby after delivery, inquire about any gross anomaly or any facial features which are dysmorphic. If it was intrauterine death or stillbirth, inquire about whether it was old or fresh by asking about the peeling of the skin or molded skin present, any autopsy done of that intrauterine death or stillbirth baby. So this was the obstetrical history, and then you will be easily able to rule out your differentials and narrow down your differentials to make your diagnosis. Then if the patient is pregnant with current pregnancy, so quickly go through the trimester-wise history to receive the particular points to rule out any particular problem. So in the first trimester, inquire about the mode of conception, Since assisted reproductive techniques and IVF is one of the cause of bad obstetrical outcome, to rule out torch infection, inquire about fever, flu, rash, any pets, particularly cats at home, any OGTT done or not, to rule out diabetes, and history of aspirin intake. So in the second trimester, inquire about anomaly scan done or not, its findings, whether it was normal, particularly ask about the patient whether your anomaly scan was normal or not, any poly or oligohydramnios, and intrauterine growth restriction, because it can be either due to the placental insufficiency or any infections like TORCH or any other chromosomal abnormalities. So to rule out preeclampsia, inquire about headache, abdominal pain, and increased blood pressure and antihypertensive medication intake. If the patient is experiencing jaundice, rule out obstetric cholestasis or viral hepatitis. Again, any OGTT done or not. So in the third trimester, inquire about any ultrasound or Doppler done and what were their findings, whether the fetal movements are satisfactory to the mother or not, any vaginal bleeding history to rule out recurrent antepartum hemorrhage, any placental abruption, any history of preeclampsia. So this is how you can easily take the history of the trimester wise to rule out your particular points. And the rest of the trimester-wise histories are as follows, which I have already told in the previous videos. So if the patient has been admitted due to any particular problem, inquire about any treatment taken, any oral or any injectable, any side effects of that particular treatment, fetal-maternal monitoring done or not, which includes the blood pressure monitoring, vitals monitoring, BSL level records, CTG and vitals. Any investigations done so far to rule out the particular problem. Discuss the mode of delivery and contraception if the patient is at term and ask for the steroid cover. If the patient is not currently pregnant, but however come with the pre-pregnancy for the pre-pregnancy counseling, then ask about the detailed obstetrical history, which I had already mentioned in the table. If it is easier for you, then tabulate the bad obstetrical history so that you must not miss any of the single point to be asked. Inquire about the paternal age and comorbidities because increased paternal age is also one of the risk factors for recurrent miscarriages. Inquire about maternal comorbidities, which include diabetes, hypertension, HEPLA. You can ask any history of clot formation, any history of DVT, deep venous thrombosis, any family history of HEPLA and SLE or any other bad obstetrical history to rule out HEPLA, any history of thyroid problems, any uterine anatomical defects. Any HEPLA workup is suspected done or not, in an investigations done, ask if the patient said, yes, I have been investigated, then inquire and ask, please show me your investigations or reports, which can include the antibiotic testing, HbA1c, TFTs, and thyroid peroxidase antibodies and the blood group to rule out Rh isoimmunization. And then inquire about any treatment taken or not, any history of anticoagulants, both oral and injectable in the form of Taxane. So this is how we can master the pre-pregnancy history and rule out the differentials. So then inquire about in the gynae history if there is any recurrent miscarriages. Inquire about any uterine abnormality since birth, any surgery done for that, any history of polycystic ovarian syndrome, and the mode of contraception used by the patient. If on the basis of the previous history and the current history, if you inquire there may be any cause of the cervical insufficiency, to rule out the causes, you can ask about any history of cervical trauma, any during childbirth, any previous cervical surgery, for instance, cervical conization and leads, any collagen disorders, and any family history of connective tissue disorder, or any congenital cervical abnormality. In the past history, if you have gone through all the history above and then still any point is missing, so in the past history, you can still again inquire about diabetes, hypertension, autoimmune, SLE, APLA, and thyroid. Any drug history, for instance, Clexine or any other drug. Then in the family history, inquired about congenital anomalies and genetic diseases that runs in the family and a history of thrombophilias or clot formation or DVT formation and stroke or MI. Personal history inquire about the smoking, alcohol, caffeine, cocaine. These all led to the bad obstetrical outcome both in the form of recurrent miscarriages or either the intrauterine death. So these are the risk factors for the recurrent miscarriages: advanced maternal and paternal age, black ethnicity background, smoking, alcohol and caffeine consumption, women with a BMI of less than 19 or more than 25 kilogram per meter square, any history of APLA, chromosomal abnormalities, congenital uterine abnormalities, and thyroid dysfunction. So these are the causes of intrauterine death, which can be divided into the fetal, placental, and maternal causes. And the fetal includes cord accidents, fetal-maternal hemorrhage, chromosomal disease, and structure abnormalities, infections, for instance, TORCH, fetal-fetal transfusion syndromes, for instance, in twin gestation, fetal anemia. Placental causes include preeclampsia, APLA, or any other thrombophilias, smoking, or any other drug abuse, for example, cocaine, caffeine, and any other smoking. So the maternal causes includes rhesus disorders, congenital cardiac diseases, any renal problem, any off cholestasis history, diabetic ketoacidosis, and uterine abnormalities. This is the stillbirth classification systems which are amended Aberdeen's, extended Wigglesworth's, and perinatal disease, perinatal Society of Australia and New Zealand perinatal death classification. The recode classification is very, very important. You must know about the recode classification, the codec, the cause of death and associated conditions, and the tulip classifications. So let's see it again as a template. So this is how you can easily take the and masters the bad obstetrical history, which is one of the very haunting and the tricky history in the from by the obstetric patients. So this is the template in the tabulated format. Ask about the obstetrical history first. If it is very significant, then the front pregnancy history. Then during admission, if the patient is admitted, if the patient is not pregnant, skip this pregnant history trimester-wise table and hospital admission stay. Just inquire about the pre-pregnancy counseling, the rest of the history template to be followed. These are the risk factors, the causes of intrauterine death, and the stillbirth classification system, among which you should know about the recode classification, which is very important. And I hope by the end of this video, now you will be able to easily take the history of the bad obstetrical outcome. So do subscribe the channel, and for more updates, please like and subscribe the channel. Thank you and good luck.